Okay, case number 6. Another usefulness of bedside echo. A 68-year-old patient walked in complaining of asthma. No previous cardiac history, no previous history apart from asthma. He has been using his salbutamol a lot, and did not want to come in as afraid of the COVID-19, and this happened very recently. His symptoms were like he was out of breath for a few weeks, and he was not complaining of any chest pain. He did not have a collapse, but he had an episode of chest pain about 2 to 3 months ago, or something like that. This is his parasternal short axis view. This is meant to be his left ventricle, which is, you see, it's not moving as well as you kind of expect it to. Especially his anterior lateral walls. This is his better view of the apical four-chamber view. You see this apical wall is not moving as much. His lateral free wall and the septum, very little movement. He had pleural effusion. That's his liver. This is his right side of the posterior view of his lung. And he had these white lines on his lung, windows everywhere. These are called B lines. All right. All right. Heart failure, bread and butter of echocardiography, a bedside echocardiography. Generally speaking, the left ventricular function is impaired. As a rule of thumb, the walls do not want to get too close to each other. And you can see the evidence of pleural effusion easily, and the B lines. The B lines are the super white lines going all the way down. That shows as a marker of a wet lung, especially if you see more than 3 of them in every window that you look. Just bear in mind, not everyone with B line is COVID-19. Look at the heart. I want to talk about the management of it, especially this gentleman who was in, as you could see on his an echo, he was in AF as well. The question is, again, with these patients in new heart failure and AF, do you want to do rhythm control or rate control? European Society of Cardiologists, up to date, and name it pretty much any guidance or any papers, suggest that rhythm control is not superior to rate control in the management of heart failure and AF. To beta block or not, a question I get asked a lot, these patients, is the fact that the European Society of Cardiology suggests it is something that needs to be started cautiously. If someone is not terribly congested, you can, and they're not symptomatic and they are in AF, you can start beta blocker. And bisoprolol starting at 1.25 and with a gradual increase to 10 milligrams, it would be your ideal initial regimen. But if the patient is symptomatic and not stable, avoid beta blocker. Rather, you can just opt in for either digoxin or amiodarone. How do we treat this gentleman? We gave him ACE inhibitor because there's a strong evidence that the decree reduces the mortality and morbidity. Furosemide to relieve his symptoms of being out of breath and congested, to relieve all those B lines. And we gave him digoxin 500 micrograms IV loading dose because of his fast heart rate. And we gave him apixaban because obviously with a score high on his CHA2DS2-VASc score. And obviously we did not give him any more salbutamol.